So I'm going to talk to you a little bit about Mississippi. You'll hear me interject and let you know a few things about Mississippi for those of you that have never been there. It's kind of a unique state in that it's mostly rural. It absolutely is. There are only 3 areas in the state that are even remotely considered urban, and they really aren't urban. Up near Memphis, the South Haven area, then there's the Metro Jackson area, and then the Mississippi Gulf Coast. So telehealth is pretty important in our state. The objectives of this presentation are just really to let you know about our remote patient monitoring program that started with a pilot project that we did in the Mississippi Delta, specifically focused on diabetic patients that were uncontrolled, giving them more support in the home. Because we know that it's quite difficult to give the patients all the education that they need in an office visit. I mean, you're doing what needs to be done in person at that time. It's also pretty heavy to lay all of that on a patient when they've been newly diagnosed with diabetes. Every time they come to the office, they're full of anxiety. They have all of these thoughts about what's going on with them. So it's hard to get education to soak in. So we did this. And then I'll tell you about what it took for them to qualify for the pilot project, but then also where we are now with remote patient monitoring. We learned a lot, I can tell you that. Let's see. So this is what we like to say we're doing. We're transforming healthcare delivery. We're not changing anything about what we do, for patients. We're just changing the way we do it or adding something to it. Our hope and our belief is that we will stop saying telehealth at some point and it will just become a part of healthcare. So a little bit about our state. 53 of our 82 counties are currently more than a 40-minute drive to any kind of specialty care. That may not seem like a lot. Here she was talking about being in an urban area and what parking costs. But for these people to get to a specialist, you're talking about if they're elderly and they don't work and they don't drive, you're talking about their child or someone has to take off work to take them to an appointment. A 40-minute drive is really about an hour, for them. Then they have to stay and wait, in a doctor's office, be there all day. Then they have to have lunch, and then they have to do it all over again to get back. So there are lots of things that they think about when we tell them you have to go to Jackson for a specialty care visit. So that's very important to know about our state. And we also are the only academic medical center and the only level 1 trauma center in our state. So it is our mission to take care of all the people in the state, not just the ones that are centered there or choose to seek us out for primary care or tertiary care. And this is giving you a map just so you can see our reach across the state. Everywhere that there's blue shaded in, and we actually have a couple more. Adams County was our most recent telehealth launch. But everywhere you see blue is where we have some kind of telehealth in our state. And these are the types of settings in which, most recently, the patient homes, and that's what I'm going to talk about today. So back in, I think it really kind of started in 2014, we began work to create a diabetes telehealth network. We knew that we could not do all this ourselves because at this time, we did not have funding for this. It was not a grant-funded project. We basically had partners that offered their services, whatever that might be, to make this a success. So UMC, what we offered was the clinical arm of it, the clinical arm, and we also had representatives from our School of Nursing and the research arm to help us with the research piece of it. We had a vendor, an outside vendor, that said, we'll do the devices. We'll help with that piece and the technical support. So, and then also a telecommunications provider in our state offered their services too, because we know that these patients may not have internet service. So the objectives of the study were to provide daily monitoring of the patients of their biometrics using telehealth. So for many, this was their first introduction to any kind of technology. That was a challenge. And our clinical goal was to achieve a hemoglobin A1C reduction of 1% in at least 75% of the participants. As you can see, we were trying to be very realistic in what we were hoping to do, just to see if anything really happened. They had to be 18 years of older. They had to have a current diagnosis of diabetes, hemoglobin A1C of 7 or greater, and of course, many of them had hemoglobin A1Cs much higher than 7. They had to be a patient at North Sunflower County Medical Center. Now, if they were not a patient of North Sunflower County Medical Center and they wanted to participate in the study, they could. That was kind of just our hub for them to go in and get the education, to pick up their kits, to have someone to contact if there were any issues. And then also we did our lab draws there. And then they could not be pregnant. And this is actually what they received. So the patient consents, they would tell them all about the study, what we're going to actually do for them, and they consent. Now, in order for us to consider them able to do this, they really just had to be willing, and we didn't have it, high educational level. I think it's 3rd grade level of reading, but they really don't have to read. That was one of the great things about this kit, is they could actually have it read it to them. So we could turn it on to where it asked them for what they needed each day. So the patient gets this kit. It is an iPad mini, actually, and it has peripheral devices in it that were all Bluetooth. So they got a blood pressure cuff and they got a glucometer that was Bluetooth with the kit. And we showed them how to use that each day, and they got to determine what time of day the kit went off, what time of day they would do their health session. That's important in Mississippi because we do have a lot of farmers, that get up at 2 or 3 o'clock in the morning and they want to get that done before they go out for the day. And then you have others that don't work, and maybe they want to do theirs at 11 a.m. or 11 a.m. or 12 p.m. in the day. So they determine what time the kit goes off and what time they're going to do their session. That session consisted of little tidbits of the educational curriculum from the American Diabetes Association. So it's not new information. It's the same information that all clinicians or all educators are teaching their patients about their diabetes, but it's not all at one time. It's just a little bit. So people are willing to sit down for 10 minutes and do something. So they go through the educational sessions, and then they collect their biometrics. So it'll say it's time to take your blood sugar. They take it. It's automatically uploaded into the system. Now, what happens on the back end, the piece that we did for this study, was we have RN care coordinators that are assigned these patients. So they actually have a dashboard on their end. So when the RN care coordinator comes into work each day, they get to see those patients stratified by whether they had a violation or not. It's important for me to let you know that those parameters for those patients were not the same for every patient. They were all individualized. So if their provider signed them up for the program, they said they wanted to be on it, they actually got to determine what the parameters would be for that patient. So some, the goal was to have their blood sugar 200 or less. For some, our really extreme cases, it might have been for their blood sugars to be 400 or less. You just didn't know. And we could change that, at any point. So if the patient did have a violation, the RN care coordinator would then call the patient and see what was going on. Now, that piece of it is very important too, because it wasn't, I see your blood sugar is 400, what did you do? It wasn't that kind of thing. It was, how are you doing? Motivational interviewing, trying to find out exactly what happened so that we could offer a personalized intervention for that patient. A great example is we had a patient who is from Italy. Living in the Mississippi Delta. And of course, he maintained his same customs as much as he could. So we know he had a diet, that was high in carbs, and it's a diabetic patient. We are not going to get him to stop eating the pasta and all. But what our nurses are able to do is to help that patient understand how he could still have pasta instead of telling him he could not have it. So when he starts telling us what's going on, what he ate the night before, what he had with it, then we're able to say, okay, here's how you can do that if you know you're going to do that. The same thing with birthday cake. Grandparents are going to eat birthday cake at their grandchild's birthday party. So we were able to help them understand how, if you know that's what you're going to do, this is what you need to do in the time period leading up to that and the time period after that. So it's more health coaching, but the goal of it was really to empower patients to be able to take care of themselves. This is not necessarily a long-term fix. This is about 4 months. Well, now it's about 4 months. For the study, they were on it for 12 months. That's something we learned in the study, was that 12 months was too long. That they get tired of it and you kind of reach what you are seeking to achieve by then. This is what it looks like for the patient. So you see it's very simple. I'm gonna look at. I really wanna make sure I get a chance to go over this. These were our preliminary results. We are still in the data analysis piece. The study is complete now. But this is what got the attention of our Medicaid, our payers, and our legislators. So in the first 100 patients, we actually had a hemoglobin A1C drop of 1.7%. We found 9 diabetic retinopathy cases. That's huge because there are no ophthalmologists in the Mississippi Delta. So we did it through telehealth, and these were identified. So now these patients know that they have this condition. We weren't really trying to affect weight loss, but we did have a cumulative weight loss of 71 pounds, and we saved about 10,000 miles. The miles in this case are really, really huge for these patients. But here's the biggie. This is actually what got their attention. In those 100 patients, we did not have any ER visits or hospitalizations for diabetes. That's huge because that's what they do. When something goes wrong, they wake up in the morning, their blood sugar's 400, oh my gosh, they don't even think about that cake they ate, and they show up in the ED. That's an expensive ED visit for us to tell them, take your medicine and go home, So we took that information to Mississippi Medicaid, we shared it with them, and they actually did this for us, which is huge because they bought into it early on. And they gave us these numbers and said that if 20% of our diabetics in the state, just 20%, were on a program like this, it could potentially save $189 million a year. So we did get reimbursement before the study was up for remote patient monitoring. So that's a pretty big deal. We're very excited about that. So now we have expanded to manage other chronic conditions. Right now we are live with CHF, hypertension. We'll go live with asthma and COPD this summer. We're just waiting on those devices to be Bluetooth. And also we had some groups that we weren't expecting to ask us about remote patient monitoring. So we're currently doing post-renal transplant, post-bone marrow transplant, about to do PKU. So you can adapt this to any group. So that is what we're doing. We do get reimbursed from all payers. Of course, the rates vary greatly by payer. And what dimension is transplant patients. And this is what our patients had to say about it. This is what I'm going to end with. This is Miss Annie. Miss Annie is about 76, 77. She did not have a smartphone or computer or anything like that before starting this study. She wanted to do it though. She did it, we taught her how to use it, she was successful with it. Now she walks to her library so she can blog about telehealth. She tells all the people in the community about telehealth. So she's kind of our spokesperson for this. And we know that we all teach our patients what they need to know about diabetes. But I think it's because they're getting it in little tidbits and it's repetitive, that it kind of sticks with them when they say, I never thought to look in my shoes. I know we tell every one of them, how important foot care is and to look in their shoes, but she probably got it 4 or 5 times, during the course of that, of those sessions. So, thank you.